Al-Fatiha. All right. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to our supervisor, Dato Dr Fadzil, and to all of you. Today we'll be presenting on two topics, which are child with breathlessness and child with cyanosis for our problem-based arena. So I'll be the first presenter, and my name is Fatiha. Next. So these are the outlines of my presentation, started with introduction up till management. Next. For the introduction, initially, what is meant by dyspnea? So based on Davidson principle, it stated that dyspnea is a feeling of uncomfortable need to breathe, while on the other hand, based on up to date, it stated that it is a subjective experience of breathing discomfort that is comprised of qualitatively distinct sensations that vary in intensity. So in simplest form, dyspnea is a subjective sensation of difficult, uncomfortable breathing, and it is usually accompanied with tachypnea, which is increase in respiratory rate. Next. In terms of causes, in illustrated pediatric, it's divided into infant and older child causes of acute breathlessness. For the infant, usually it is due to bronchiolitis, pneumonia, heart failure, foreign body, and severe anemia. While for the older child, might be because of asthma, due to recurrent asthmatic attack, pneumonia or lower respiratory tract infection, foreign body aspiration, and heart failure. Next. So how do we approach when patient presented to us with breathlessness? So basically what is very important is that we need to get the relevant history taking and proper physical examination finding so that we can know what exactly the diagnosis that the patient might having and what for the management that we are going to give to the patient. So in terms of history of presenting illness, it is very important to know in details regarding the onset and durations of breathlessness, whether it is sudden or gradual in onset. Sudden usually due to asthmatic attack, pneumothorax, while gradual usually caused by congenital heart disease and anemia. And then whether the breathlessness occur at rest or during exercise induced. So we need to know that because we need to assess the severity, whether the breathlessness is the first time or recurrent episode, such as in acute exacerbation bronchial asthma, and then frequency, duration of breathlessness, and timing. So for the timing, it is very important that in acute exacerbation of bronchial asthma, the symptom usually worsen during the night times or early morning, while in croup, the symptoms often start and are worse at night. Well, in terms of precipitating factors, we have to know that whether the patient had upper respiratory tract infection, exposure to dust or smoke, which is one of the contributing factors that could worsen the asthmatic attack, allergen, pets, or any allergic toward certain medication or foods in which patient were presented with breathlessness. And then in terms of relieving factors, it is important to know whether if this patient had underlying asthmatic attack, whether the use of bronchodilator does relieve the episode of breathlessness. Next. In terms of severity, it is basically important to classify patient whether they are having mild, moderate, or severe attack, or in worst case scenario, it can be life-threatening. So the parameter include breathlessness, talk-ins, whether in sentences, phrases, words, or in life-threatening, unable to speak at all, the alertness, the usage of accessory muscles, and wheezing. Next. Other associated symptoms that we could ask related to breathlessness, that whether the cough, it is productive or not, non-productive cough, barking cough. Barking cough, usually it is due to tracheal edema and collapse, which is suggestive of having viral croup, or whooping cough, which is in pertussis. Well, and then the other associated symptom that we should ask whether there is any associated noisy breathing, such as wheezing, which is in asthmatic, stridor in upper respiratory tract obstruction, and then whether there is drooling of saliva, difficulty or painful in swallowing, which is suggestive of acute epiglottitis. And then whether there's change in voice, such as muffled voice, or maybe the child is reluctant to speak, and this basically happen in acute epiglottitis, and then hoarseness of voice due to inflammation of the vocal cord, in which patient will presented with high-pitched voice. And then whether there's fever, and then pale or bluish discoloration of the child, which is suggestive of having severe anemia or congenital heart disease. And then chest pain. Next. So this is the related associated symptom that we could ask based on specific diagnosis. If we suspect that this patient might have bronchiolitis, we should know that the age of a patient who having bronchiolitis is at the, it happened to occur especially in the age of 1 to 6 months, and it's proceed with mild common cold, low-grade fever and cough. Well, for pneumonia, fever, the symptoms usually had fever preceded by upper respiratory tract infection, cough, lethargy, and poor oral intake. However, in severe form of pneumonia infection, some of them are unable to drink or having poor oral feeling, and sometimes can present with drowsiness and convulsions. While in bronchial asthma, the other relevant symptoms that we show us is regarding the noisy breathing, which is wheezing, chest tightness, and any feeling of chest tightness, cough that particularly occur at night or early morning, and then symptoms of respiratory infection. Next. And then for croup, we need to ask regarding is there any barking cough, stridor, or hoarseness of voice. Barking coughs like batuk macam bunyi macam bunyi anjing, and then preceded by low-grade fever, cough, common cold. All right, in terms of acute epiglottitis, we know that acute epiglottitis, the onset is usually very acute. So the symptom that we could ask is whether there's fever preceded with upper respiratory tract infection, cough, lethargy, poor feeding, and in severe form of acute epiglottitis, patient are unable to drink and having poor feeding, drooling of saliva over the chin, reluctant to speak due to the intense pain at the epiglottitis, and then drowsiness. And it is also important to inquire regarding the immunization history of the patient. Is it up to date or not? Because we know that Haemophilus influenza B infection is one of the etiology that causes this acute epiglottitis. And then foreign body aspiration. So usually it occurs at the age of below than 3 years old, and it can be divided into upper airway obstruction and lower airway obstruction. For the upper airway obstruction, usually patient will present with sudden coughing, choking, drooling, dysphagia, and stridor. While for the lower airway obstruction, there could be fever, cough that due to the infection. However, the presentation may be delayed to weeks as compared to upper airway obstruction. Next. Then is anaphylaxis. We inquire about whether there is swelling over the face, any urticarial rash formation, and for the heart disease and the other systemic disease that we could also include if the patient might present with acute breathlessness is having heart disease, in which for infant or young children that might suspected to have heart disease, they usually have symptoms of poor oral feeding, easy fatigability, poor weight gain, while for the older children, they usually had exercise intolerance, orthopnea, chest pain, and palpitation. While for anemia, it is important to ask regarding whether the parents notice that their child is getting more pale than usual, lethargy, poor feeding, and dizziness. Nice. And then it is also important to know regarding whether before this, is this patient having any prior episode of acute breathlessness to current presentation. And then we also need to know whether the patient had any previous hospitalization and treatment, in which in case of acute exacerbation bronchial asthma, they usually have a recurrent episode of the exacerbation. Then we need to inquire whether each episode, does they need to be admitted to the hospital, and then for how long they have to be admitted, and what is the treatment that they have received, and what for the management that had done during the admission, and does the patient had any history of ICU admission. And then we need to also know regarding the underlying disease, such as atopy, asthma, eczema, allergic rhinitis, heart disease, or might be because they had underlying congenital heart disease, rheumatic heart disease, and hematological disease, which is thalassemia, and diabetes mellitus type 1 disease, in which patient were presented with diabetic ketoacidosis. Next. And then the other relevant history taking that should be asked is regarding the birth history. It is very important to know that whether the patient had been born preterm or term. This is because infant that born prematurely who develop bronchopulmonary dysplasia or with underlying lung disease such as cystic fibrosis or congenital heart disease are most at risk for severe bronchiolitis. And then we need to ask regarding the immunization history, whether it is complete immunization. We know that Haemophilus influenza B infection is one of the etiology for the causes of acute epiglottitis, and then nutritional history, whether there is any specific food that the patient are allergic to, in which when they started to consume, they had the symptoms of acute breathlessness. And then family history, atopy and asthma. It is very important to inquire that whether if the parents of the child both are having atopy and asthma, so the risk for the child to have asthma in future is higher. And then thalassemia, and then social history regarding the home environment, whether it is a good whether it is a very good environment in terms of hygienic, because we afraid that there might be exposure to the dust or smoke, which is the triggering factors for the asthmatic attack. And then school absenteeism, which is one of the important things to know, that whether if the patient has severe asthma, that sometimes they need to absent from the school. Next. Okay, in terms of physical examination, so what we have to actually look is that on general assessment, whether the patient is restlessness, agitated, ill-looking, which is usually we will see in patients having acute epiglottitis and lethargy, any chest deformity, any chest recession, stridor, wheezing, nasal flaring, increased accessory muscle use, the positioning of the child, whether in sniffing or tripod position. I will explain after this. Clubbing, if we suspected this patient might have been congenital heart disease, pallor or sinuses, for example, in severe anemia, so they usually look pallor as compared to usual. Next. So this, as you guys can see, the tripod position, the picture on the left side. So it is a characteristic posture of a child with acute epiglottitis, in which the child will leaning forward on hands in the tripod position with mouth opened, tongue out, and head forward and tilted up in a sniffing position on the right side. So basically this is done as an effort to relieve the acute airway obstruction secondary to swollen epiglottitis. Next. So these are the several signs of respiratory distress that we should look on, which is nasal flaring, cyanosis, like the picture, grunting, use of accessory muscle, and chest retraction, such as subcostal, intercostal muscle, sternal muscle. Next. So this is other sign that you could look on. You can read it. Next. Okay, then what is important is basically to monitor the vital signs. So we know that for a tachypneic child, it is very important in child with respiratory condition. So apnea may be the initial manifestation of bronchiolitis or pertussis. While for heart rate, usually patient will have a tachycardia. So it occurs due to increase in sympathetic tone. While for the oxygen saturation, we know that patient presented with breathlessness. Most of the time, the oxygen level is low. Quite sometimes they presented with hypoxemia. It is stated that if values less than 90% indicates is significant tissue hypoxemia. And then the temperature, whether the patient is febrile, we should know that any precipitating factor, maybe the patient had upper respiratory tract infection, which is patient presented with fever, and then anthropometry, which is failure to thrive, which usually occur in heart failure or severe asthmatic patient. Next. While in terms of respiratory system, so it is one of the important systems since patient presented with acute breathlessness, in which on inspection we should look on the breathing patterns of the child, any chest deformities such as Harrison sulcus, pectus carinatum, and then palpation, whether there's structural deviation to rule out pneumothorax, and reduced chest expansion in asthmatic, percussion, whether if DEL usually indicate consolidation, usually occur in pneumonia, stony dullness, pleural effusions. Stony dullness usually indicates pleural effusion, while hyperresonant indicates asthma. Well, in terms of auscultation, we should note that whether there is any reduce in breath sound, bronchial breath sound, bronchi, which occur in asthmatic patient, and bronchiolitis and crepitation, which is suggestive of having pneumonia infection. Next. If we suspected that the acute breathlessness might be because of the patient having congenital heart disease, so we should proceed on the cardiovascular examination. So whether there is jugular venous distension, displaced apex beat, or gallop murmur is suggestive of heart failure. Next. In terms of investigation, so basically the investigation is depend on the clinical judgments of how do we actually look on the patient. So I divided it into bedside, laboratory, and imaging. For the bedside, so there is a peak expiratory flow rate. So basically, peak expiratory flow rate, it is suitable to be done on most children over 5 years of age, because they can follow the instruction carefully. And then what indicates here is that poorly controlled asthma will lead to increase in variability of the peak flow rate meter. And then ECG, for ECG, we might suspect that this patient might have been heart disease or heart failure that caused the patient to have acute breathlessness. So most of the time, if the patient of the age of more than 12 years old, the most common ECG finding in pediatric heart failure patient are sinus tachycardia, left ventricular hypertrophy, and STT segment changes. While for the laboratory investigation, we could perform full blood count, in which if there is an increase in total white blood cells, so it might suggestive of infection is going on. And then if there is a reduce in hemoglobin level, so might be because of anemia that in which patient presented with breathlessness. And then we proceed on ultra blood gases, in which ultra blood gases is very important since patients are in a hypoxia state, and sometimes they will present with respiratory acidosis. And then throat swab. So basically, throat swab is very important to detect the presence of group A Streptococcus bacteria, which is the most common cause that could cause other infections such as scarlet fever, abscesses, and pneumonia infection. And then for blood culture and sensitivity, it is important for the aid in antibiotic administration based on the culture of the bacteria. And then for the last laboratory investigation that we could done is renal profile. We know that most of the time patient will have poor feeding. So the poor feeding might cause the patient having electrolyte imbalance. So that is very important to perform renal profile as one of the laboratory investigation. And the next one is imaging. So imaging, there is chest radiograph, lateral neck X-ray, and echocardiography. For chest X-ray, basically what we will look is if we suspected that this patient might having heart failure. So most of the time they will be presented with cardiomegaly. And cardiomegaly in pediatric chest X-ray is suggested by a cardiothoracic ratio of 60% in neonates and 55% in older children. And beside of cardiomegaly, we can look on whether there is consolidation, suggestive of pneumonia, whether there is pleural effusion, whether there is pleural effusion sign. And then for the lateral neck X-ray, so basically we done that if we suspect that this patient might having acute epiglottitis, in which the finding usually found there is thumbprint sign. Thumbprint sign in which it indicates a swollen epiglottitis. All right, and then echocardiography. So we know that echocardiography is done when we suspected that this patient might having heart failure. And from the chest X-ray itself, if chest X-ray reveal that there is cardiomegaly, so might be that if we perform the echocardiography, the patient might have been ventricular dilatation on the on the echocardiography, which is suggestive of heart failure. Next. So this is the certain X-ray related to a specific diagnosis. So if we suspected it is acute breathlessness, it is due to viral groups. So based on the history taking and based on the physical examination finding. So basically on the chest, on the X-ray, we will found there is stipple sign in group, which is stipple sign, which is it indicates that tapering of the upper trachea, stipple sign. While the next picture is consolidation at the right middle lobe, which is might suggestive pneumonia. And then the last one is a thumbprint sign in acute epiglottitis, indicates swollen epiglottitis. Next. Right, in terms of management, we need to know that the management is basically most of the time it is conservative and supportive to the patient. So if the patient presented with acute breathlessness, what we have to do is actually to secure the ABC, airway, breathing, and circulation. So for the airway, make sure that the patient are having pattern airway. If we suspect that there is any obstruction due to fluid, anything, so we have to clear the airway by using the suction, and then we can opt for adjuncts such as using oropharyngeal airway or nasopharyngeal airway if the patient presented with severe hypoxemia. Well, for the breathing, so we can provide necessary oxygen support such as using the nasal prong or CPAP, and then at the same time we have to monitor the oxygenation level by using the pulse oximetry. But in terms of circulation, we have to monitor the vital signs such as the heart rates, the respiratory rate, and then establish vascular access for fluid administration or medication. Next. All right, for the supportive management, so basically, after we stabilize the patient from the ABC, so we will do another management which is specific to the disease, specific to diagnosis of what the patient is having. Okay, for the supportive management, if the patient might have been upper respiratory tract infection presented with fever and then exacerbate and then triggering the bronchiolitis event, so basically we can prescribe antipyretic, which is a paracetamol syrup to the child, and then antibiotics specifically for pneumonia infections. And at the same time, we have to monitor hydration status of the patient and the vital signs, and then encourage oral intakes. And what importance is the patient and caregiver education. Why these things are very important? Caregiver education, for example, we have to expose in terms of good hand hygiene to prevent cross infection, and then we need to assess the proper inhaler technique for the child, and then we have to make sure that the parents should always be aware with the condition. They should be aside of the patient while using the inhaler, and then we also need to acknowledge the parents, to acknowledge the teacher if the child cannot involve in any sport activities that could trigger an asthmatic attack. And then unimmunized infant should get vaccinated, because we know that the event of acute epiglottitis, it happened when the patient is not receiving the proper vaccination, which is Haemophilus influenza B vaccine. And then what important, lastly, is avoid any triggering factors if the patient had underlying bronchial asthma. So we need to avoid all those triggers that basically can exacerbate or worsening the symptoms of asthma. So next. So that's it. Any question?
Any questions? Generally okay lah, ada outline actually I tak agree sangat breathlessness ni. Because breathlessness is not a chief complaint. Usually chief complaint will be tachypnea or shortness of breath. Usually 3 years old, 4 years old child cannot complain breathlessness because they cannot explain it to anybody. So what we most of the time we look at the child, we notice shortness of breath. Okay, the second thing is that your disease mainly focus on respiratory, and second you focus mainly on the acute. In any case, they are acute and chronic. chronic breathlessness, chronic shortness of breath. And then severity, okay, severity there is for most of the wheezing episode, but those like bronchiolitis have their own way of severity assessment. Croup also have their own way of severity assessment. But by right is acceptable lah. If you remember or something to base your basis, then it's okay. Bronchopneumonia, you can use, basically something like that. But it gives you ideas how to assess the severity. And then causes, okay. And then investigation is bit okay lah. And the other history, okay. Basically give you some ideas how to go about of patient with shortness of breath. This is the most common presentation that you've seen in the ward. But then shortness of breath is not respiratory or respiratory or heart only. It also mentioned a little bit of anemia, sepsis, metabolic acidosis. All those can also come with. So there are ways to remember the causes. It's either you from the most common to most rare, or you go by system. Then you can identify it better. But it doesn't matter. The most important, you know how to make diagnosis. Any other question?
I would like to ask regarding bronchiolitis. Do we actually give salbutamol? Because some I read it have benefit, but some says not recommended.
Apa? Dalam ward kita beri tak?
Not sure. Tak jumpa lagi.
Tak jumpa. We give and we don't give. Depend to cases. Anything else? We give and we don't cases. Depend. Okay, anything? Any other questions? Tak ada. Okay, next.
Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Nasrul Habitat Abdul Wahid. Now let's move on to the second part of the problem-based seminar on a child with cyanosis. Okay, so this is the my content of presentation. Okay, so before we go any further to the cyanosis, let's take a look on an example of case scenario where there is a 3-month-old child who was brought to emergency department with history of severe bluish discoloration while crying. Okay, so before we go any further to the case, let us recap what is cyanosis. So by definition, cyanosis is bluish discoloration of the tissue due to an increased concentration of deoxygenated hemoglobin in the capillary bed. And there are two mechanisms which can cause cyanosis, which are systemic arterial deoxygenation and increased oxygen extraction from the tissues. Okay, due to that, we have two types of cyanosis, which are central cyanosis and peripheral cyanosis. Okay, central cyanosis is due to systemic arterial concentration of deoxygenated hemoglobin in the blood exceed 5 grams per deciliter. Meanwhile, peripheral cyanosis is occur when there is increase in oxygen extraction as a result from sluggish movement of the blood through the capillary circulation. Okay, so let's move on to the causes of cyanosis. Okay, causes of cyanosis can be divided into respiratory causes, circulatory causes, and others. And for respiratory causes, the respiratory cause of cyanosis is any condition that inhibits oxygen from reaching the alveoli or disrupts its movement across the alveolar interface. So it can be due to decrease in inspired oxygen, for example, in case of smoke inhalation, cyanide poisoning, exposure to asphyxiating gases, or intentional inhalation of hydrocarbons. It also can be due to upper airway obstruction, for example, in case of foreign body, croup, thermal injury, epiglottitis, bacterial tracheitis, tracheal or bronchial disruption, and congenital airway abnormalities. It also can be due to impairment of chest wall or lung expansion, for example, in case of trauma, external chest compression, flyer chest, open pneumothorax, tension pneumothorax, and hematothorax. Apart from that, it also can be due to intrinsic lung disease, for example, small airway obstruction such as asthma, parenchymal disease such as pneumonia, and also disruption of oxygen exchange in the alveoli such as pulmonary edema. Okay, for circulatory causes, circulatory cause of sinuses may be due to mixing of oxygenated and deoxygenated blood, or structural or vascular alteration in the pulmonary blood flow, cardiac decomposition with pulmonary edema or shock. So, example of circulatory causes of sinuses are cyanotic congenital heart disease, pulmonary edema, pulmonary hypertension, pulmonary embolism, pulmonary hemorrhage, acute chest syndrome, and shock. And other than that, methemoglobinemia also can cause sinuses. So methemoglobinemia is a condition whereby there is an alteration of hemoglobin, ferrous iron of the heme are oxidized to ferric iron state, and ferric heme is unable to bind to oxygen. That's why in methemoglobinemia, patient can have sinuses. And methemoglobinemia can be divided into congenital and also acquired. So there are also other causes of sinuses, for example, major head trauma, poisoning, brief resolved unexplained event, seizure, acrocinosis, Raynaud phenomena, cold exposure, polycythemia, and also cyanotic breath holding spell. Okay, so let's move on to the approach of to a cyanotic child. So when there is a cyanotic child came to us, what we need to do first is we need to acquire full history from the guardian, and then we need to do physical examination, then proceed with investigation and management. Okay, so in history, what important history that we need to acquire are first the age of the patient. This is because in neonate, the common cause of sinuses is cyanotic congenital heart disease and polycythemia. Meanwhile, in children, the most common cause of sinuses is due to respiratory disorder. Second, we need to know whether the patient has history of fever or not, because we want to rule out any infectious causes of sinuses secondary to upper airway obstruction, for example, croup, lower airway disease such as pneumonia, and also shock. And then we also need to ask whether the patient has history of trauma or not, because we want to rule out any chest wall injury. Other than that, we also need to know whether the patient has any exposure to smoke inhalation or low oxygen environment, which can cause the sinuses. And then we also need to know the drug history of the patient, whether the patient take any drug that can cause sinuses, for example, amiodarone, which is being used in antiarrhythmia. And then we also need to ask about the past medical history, such as prior lung disease, for example, asthma or bronchopulmonary dysplasia. And then we also need to know whether the patient has already diagnosed with congenital heart disease or not before, especially cyanotic congenital heart disease. And then we also need to know whether the patient has any neurological disease, for example, history of seizure, breath holding spell, and also neuromuscular disease. And then let's go back to the case before. So this is the history of presenting illness, where the child was having bluish discoloration while crying, and the mother gave a past history of such episodes with spontaneous recovery since birth. Otherwise, there was no history of fever, trauma, and also exposure to smoke. Birth history, past medical history, and drug history were unremarkable. So the main point here is that the sinuses occur during crying, and it occurs multiple times. Okay, so after we already acquired thorough history, what we need to do is we need to proceed with physical examination. So generally, what we need to look for is we need to look for signs of sinuses, especially at the nail beds, tongue, and also mucous membrane. Okay, sign of sinuses is less apparent in the skin because sometimes it is affected by the skin color or pigmentation. So we need to avoid looking for sign of sinuses in the skin. And then we also need to look for sign of peripheral vasoconstriction, which can cause peripheral sinuses, for example, cold extremities. And then we need to check the vital signs of the patient, for example, the temperature. We need to know whether the patient is having fever or not. because fever may indicate infectious causes of sinuses, for example, pneumonia, croup, or bronchiolitis. And then we need to measure the respiratory rate of the patient. Tachypnea usually a sign of respiratory distress, so we need to measure the respiratory rate. And then for the heart rate, the patient can either have tachycardia or bradycardia. Tachycardia is more common in sinuses, but if the patient has bradycardia, it may indicate a cardiopulmonary collapse. And then we also need to measure the blood pressure. Okay, and then after general examination, we need to proceed with systemic examination. Okay, since the common cause of sinuses is from the respiratory disease and cardiac disease, so these two systems are our concern. So we need to proceed with respiratory examination and cardiac examination. Okay, so in respiratory examination, what we need to look for is we need to look for signs of respiratory distress, for example, tachypnea, nasal flaring, grunting, and also retraction. And then we also need to look for any signs of upper airway obstruction, for example, stridor, and also suprasternal retraction. Then we also need to look for signs of lower airway disease, for example, crepitation, asymmetrical breath sound, and also wheeze. And lastly, we also need to look for any signs of traumatic lung injury, such as abnormal chest wall movement, chest wall ecchymosis or abrasion, subcutaneous air with crepitus, tracheal deviation, abnormal breath sound, and also focal tenderness to palpation over ribs, sternum, or scapula. And then in cardiac examination, what we need to look for is we need to look for signs of cyanotic congenital heart disease, because it is the most common cardiac cause of sinuses. So we need to hear for murmur, especially at the upper left sternal edge in tetralogy of Fallot, and also we need to auscultate for loud and single second heart sound in case of transposition of great arteries. Okay, for the case, the examination revealed that there is ejection systolic murmur at the left upper sternal border. Otherwise, other examination, physical examination were unremarkable. And the patient is basically hemodynamically stable. And then after we complete with physical examination, we need to proceed with investigations. So investigations in sinuses is divided into bedside investigation, biochemical investigation, and imaging. So in bedside investigation, what we need to do is we need to do the pulse oximetry in order to measure the oxygen saturation. And then we need to do electrocardiography or ECG to look for any right ventricular hypertrophy. And then we also can do echocardiography to demonstrate the abnormal atrial connection if we suspect the patient is having transposition of great arteries. And then we can proceed with biochemical investigation. First, we need to do atrial blood gas in order to measure the partial pressure of oxygen in the atrial blood. Second, we need to send for a full blood count in order to measure the hematocrit level, because just now polycythemia also can cause sinuses. And then we also can send for methemoglobin level, but methemoglobin level is only being done in cyanotic patient with normal partial pressure of oxygen with cardiac causes has been excluded. This is because in patient with methemoglobinemia, usually the partial pressure of oxygen is normal, but the patient is cyanotic. So we need to send for methemoglobin level in such case. And then we also can proceed with hyperoxia or nitrogen washout. Okay, hyperoxia or nitrogen washout is a test to determine whether there is presence of heart disease or not. So how it is being done is first, the patient or the infant is being placed in 100% of oxygen for 10 minutes. Then after that, they will measure the partial pressure of oxygen in the blood. And if the partial pressure of oxygen increase or elevated, that means that there is no cyanotic heart disease. But if it is remain low, then it might be possible cyanotic heart disease. And then for imaging, what we can do is chest radiograph in order to look for any lung or cardiac abnormalities. Okay, so what we can see on the chest radiograph is first egg on string sign in the transposition of great arteries. We also can see boot-shaped heart in tetralogy of Fallot. And then we also can see steeple sign, or also known as wine bottle sign in croup. So So let's go back to the case scenario. Okay, this is the investigation result for the case. It said that all lab investigations were within normal limits except for elevated hematocrit. And ECG show right axis deviation and right ventricular hypertrophy. Echocardiography revealed right ventricular outflow obstruction with right ventricular hypertrophy, non-restrictive ventricular septal defect with right to left shunt, and infundibulous pulmonary stenosis. Therefore, the diagnosis of tetralogy of Fallot was made. So after we done with physical examination, now we need to proceed with management. So initially, we need to stabilize the patient by maintaining the airway, give adequate ventilation, and give adequate circulatory support. Next, we need to correct any metabolic acidosis, electrolyte derangement, hypoglycemia, and also we need to prevent hypothermia. And then finally, we need to treat the underlying cause of sinuses. For example, if the sinuses is due to respiratory disease such as croup, then we need to treat according to the severity. For example, we give dexamethasone in mild croup, and then give dexamethasone with stabilized budesonide in moderate croup. And then we also need to give nebulized adrenaline, dexamethasone, and also nebulized budesonide plus oxygen in severe croup. But if the sinuses is due to acute epiglottitis, then we need to give IV ceftriaxone for the patient. And then if the sinuses is due to the cardiac causes, especially congenital heart disease, then what we need to do first is we need to give the empirical treatment with IV antibiotic because we want to prevent the infective endocarditis. And then we need an early cardiology consultation. And then we need to give IV prostaglandin E infusion. Why? Because we need to maintain the ductus arteriosus so that the oxygenated blood can keep circulate in the body. And lastly, surgical intervention if the patient needs. So for the case is about the tetralogy of Fallot. So what is tetralogy of Fallot? Tetralogy of Fallot is characterized by ventricular septal defect, overriding of the aorta, pulmonary stenosis, and right ventricular hypertrophy. And its severity depends on the degree of right to left shunt. So usually the patient will present with central sinuses, clubbing, gross retardation in untreated cases, loud ejection systolic murmur due to pulmonary stenosis, and also tight spell. Okay, so in investigation, what we can see is we can see the oligomeric lung field due to reduced pulmonary vascular marking and also good shaped heart. And also in echocardiography, what we can see is we can see a right ventricular outflow obstruction, right ventricular hypertrophy, ventricular septal defect, and also right to left shunt, and also pulmonary stenosis. And echocardiography is a diagnostic investigation in tetralogy of Fallot. And then in ECG, what we can see is right ventricular hypertrophy. And then the management of tetralogy of Fallot is divided into during tight spell and also definitive. So during the tight spell, what we can do is we need to hold the baby in the knee chest position, administer 100% of oxygen, and give either IV, IM, or subcutaneous morphine in order to reduce the distress and also hypopnea. And then for the definitive management is surgical intervention. There are several complications of tetralogy of Fallot. The first one is polycythemia, and in this case, maybe the patient is having polycythemia because there is a slightly increase in hematocrit level. And the second complication is cerebral thrombosis. Next, cerebral vascular accident, cerebral abscess, and infective endocarditis. Okay, so before I end my presentation, this slide shows the difference between the cardiac sinuses from pulmonary sinuses. So in cardiac sinuses, usually the patient relatively comfortable at rest, and the sinuses may worse upon crying or effort. And during chest auscultation, what we can hear is a cardiac murmur. And in chest radiograph, what we can see is that the cardiac silhouette usually abnormal, and there will be abnormal position or shape or cardiomegaly. Meanwhile, the lung fields usually normal, or there might be decreased vascularity, pulmonary vascular congestion. And ECG usually abnormal, shows abnormal rhythm or exists, and the partial pressure of carbon dioxide usually normal or low in the cardiac sinuses. and it responds to 100% of oxygen is usually not profound, or there is no response to oxygen, to 100% oxygen. Meanwhile, in pulmonary sinuses, usually the patient will be tachypneic, distressed, or there might be some retraction. And the sinuses may improve upon crying or effort. And in chest auscultation, what we can hear is we can hear crepidation and also wheezing. And during in chest radiograph, what we can see is that the cardiac silhouette will be normal or obliterated cardiac margin. It depends. And then the lung fields usually shows a ground glass appearance, pneumonia, atelectasis, pneumothorax, or etc. Depends on the causes of sinuses. And usually the ECG will shows abnormal, normal result, and the partial pressure of carbon dioxide usually increase. And it responds, usually it has a profound response to 100% of oxygen. So that's all from me. This is my reference. And thank you.
Sinuses kan big topic lah, mainly respiratory and cardiology. In respiratory, it means that is one of severe sign of severity. Whereas in cardiac, it just show more diagnosis and cause. And then and in cardiac it can be chronic. But sometimes it can be severe, but most of the time it's be just, you may tell you the congenital heart disease with certain chronic chronicity. Not common to be acute. Sometimes we do see acute one at birth only lah. Otherwise, okay lah. Any other questions?
I have questions. So if we are suspicious of cyanotic heart disease in a child, from our clinical findings, chest X-ray as well as echo, so do we still routinely do the hyperoxia test? Does it have any
hyperoxia test, usually we did it in the usually for newborn. Those who, when we have problem in deciding is it respiratory or not respiratory, is cardiac or not cardiac, because their condition we call pulmonary hypertension, persistent pulmonary hypertension. So in this case, that's the time we did it. The rest usually we just do echo and we can decide on that. And then the history can tell us definitely from the older children, is it respiratory or non-respiratory? And once you do echo, you don't need to do hypoxic test anymore, because by then you already have diagnosis. Hypoxic test is when you don't have the diagnosis, and also when you are unable to decide is it respiratory or cardiac causes. And usually we did it at the very early age, just few really 24 hours to 40 hours of life usually. Any other question?
And also, Dato, I would like to clarify for the management, if the patient like having heart disease with cyanosis, then what is the purpose of preventing hypothermia and hypoglycemia? Is it because we want to reduce the cardiac workload?
Pardon?
Is it the purpose we want to prevent the increasing in the cardiac workload?
Even hypothermia dengan
hypoglycemia.
Of course lah, you don't want the cardiac work harder to pump.
Okay.
Anything else? Okay, finish. Are you all in the campus or outside? Where you all now?
Some of us are in the campus, about 10 students.